Good morning, everyone. I'm Dr. Sheetal, chaurasia, consultant pulmonologist at Manipal Hospital, Whitefield. Today, we'll be discussing about community-acquired pneumonia, the pneumonia which is acquired in the community, as the name suggests. Uh, despite being being so much research and so much new antibiotics development, after the first antibiotic was developed almost 70, 80 years, almost 100 years back, CAP remains a leading cause of illness and death. It is one of the most important cause of mortality. And among the community-acquired pneumonia cases, the severe ones are the are the cause for most of the mortalities. Severe CAP is defined as community-acquired pneumonia that requires admission to the ICU. And out of 5 to 16% of hospitalized patients with pneumonia, they are the ones who may need a ICU care. Mortality for patients with severe CAP may be as high as 33 to 58%. So despite all the advent in the vaccinations and the newer diagnostic tests and the antimicrobial therapy, the mortality remains abysmally high for severe community-acquired pneumonias. So pneumonia, as we know, it's a cough, it's a various combination of cough, expectoration, shortness of breath, chest pain, presenting with some systemic feature like fever with chills and rigors, malaise, and some new focal chest signs on examinations, and with or without a patch in on a chest X-ray. And there's no other explanation for the symptoms. So severe, for this talk, we'll be mostly focusing on a severe CAP. And severe CAP is accepted terminology used to describe ICU admitted patients, as they might be requiring organ support. As we saw, mortality due to severe CAP remains unacceptably high. And what the data has shown that the highest mortality is seen in the patients who deteriorate over the course of their time compared to who is diagnosed as a severe CAP and were admitted in ICU at the initial, at the time of admission. So severe CAP on admission is, the mortality is 17% as compared to the people who, to 48% amongst the people who deteriorate over next on the day 4 to 7 of the illness. So because of this, it's very important to identify the severe community-acquired pneumonia cases and identify the people who are going to deteriorate in next 3-4 days. So when we diagnose a case of pneumonia, our idea should be to find out who are the patients who are going to worsen over the time. There are multiple severity scoring systems, like to name a few, PSI, Curve 65, Smart Cop, ATS, IDS criteria, which can help us in identifying these cases. PSI and Curve 65, they are good for predicting mortality, but certain young cases with no comorbidities, they can miss finding out a severe the severe pneumonia in such patients. Certain risk factors are important, like the patient-related risk factors like multiple comorbidities, elderly, age more than 65, and multifocal pneumonia on X-rays. These are the patients we should have a higher suspicion of getting higher suspicion that they may worsen over time despite appearing relatively stable during the time of admission. ATS IDSA criteria remains a useful tool for identifying the severe pneumonia cases that needs ICU admission at the outset. So Curve 65, good severity scoring system in a OPD basis when you need to identify the patients who might require a hospitalization, and it's easy to do in a OPD setting. the ATS criteria for severity assessment, which was given in 2007, either of the major criteria or more than three minor criteria, if a person fulfills, should be admitted in the ICU from the beginning. And if they don't fulfill this criteria, again, a clinical assessment of the patient and a history may give us may help us in identifying the patients which may require a ICU admission or who are going to deteriorate in coming days. So when we, the most important factor in preventing mortality remains the administration of appropriate antibiotics at the earliest. And to start an appropriate antibiotic, it is very important that we identify what could be the organisms who are which is responsible for the infection. So traditionally, community-acquired pneumonia, the microbiology remains Streptococcus pneumoniae, H. influenzae, the atypicals, Mycoplasma legionella, Moraxella, Chlamydia, and Staph aureus, mostly the methicillin-sensitive strains. Severe CAP, Streptococcus pneumonia remains the major cause of severe pneumonia, severe community-acquired pneumonias. However, with rapid tests, we are identifying more and more viral infections, which are responsible for the severe CAP. Apart from that, Staph aureus, again, both MSSA and MRSA strains are responsible for severe CAP, and to it, some 10 to 15% of cases could be from the organisms like Pseudomonas aeruginosa and enterobacterials, and which may not be covered in our empirical antibiotic treatment for the severe CAP. And we have to find out the people who may be having an infection from this, and there are certain risk factors which may help us in identifying it. Also the incidence of MDR pathogen is more in the patients, in these patients, and that has to be kept in mind when starting the antibiotics. So as I said, in recent years, the increased use of rapid molecular techniques has demonstrated viruses as an important cause, or as an important initial cause of severe CAP, which later, with a co-infection from a bacteria, leads to a patient requiring ICU care or a mechanical ventilation or vasopressor supports. So risk factors for the Pseudomonas aeruginosa and Staph aureus should be kept in mind so that the antibiotics could be adjusted as early as possible. So few of the risk factors are prior isolation of these organisms, especially from the respiratory tract. These patients should be started on anti-pseudomonal or anti-Staph aureus coverage. Recent hospitalization, regular visit to the hospitals, like as in dialysis patients, recent exposure to parenteral antibiotics, structural lung disease, like a patient with a bronchiectasis or a patient with COPD on inhalers or with fibrotic lung disease post-tubercular. All these patients airways may be colonized with atypical organisms like Pseudomonas or Staph, or sometimes bacteria, Burkholderia. So we should keep that in mind, and antibiotics should be adjusted accordingly, or at least started empirically. Inhaled corticosteroid and oral corticosteroid is another risk factor for having these organisms. So apart from the regular blood parameters and CBCs and inflammatory markers, X-ray, identifying the correct organism is very important. And what are the tests that should be done? So in a patient who is admitted in ward with pneumonia, should have a gram stain and culture of the respiratory secretions. Pre-treatment blood culture is indicated only for the people with severe CAP who are in ICU, but for the patient who are in wards need not be done. OPD basis, these tests are not done unless they don't respond to the primary antibiotic treatment. Legionella and pneumococcal, again, the patients who are admitted with severe CAP, we can do the urinary antigen test or the rapid multiplex test for Legionella. Especially during the influenza seasons, influenza testing is indicated via a rapid influenza molecular assay. So, of late, there are lot of rapid microbiological testing is done, and it should not be done for each and every patient because it may lead to unnecessary, undue escalation of antibiotic treatment, because it can identify organisms which are colonizing the airways, as well as it can identify the organism with which the patient might have been infected some time back. So it is, as per the ERS guidelines, it is indicated for patients whom we are considering starting on a non-standard severe CAP regimen, like a person who has been started on a beta-lactam and a fluoroquinolone, and we are thinking of escalating the antibiotic. It's a good time to send this test. It may help us in starting appropriate antibiotic or modifying the antibiotic appropriately. The greatest benefit of multiplex PCR testing remains that we can rapidly adjust the antibiotic for unsuspected antibiotic resistant pathogens. The 48 to 72 hours of inappropriate antibiotic therapy, which we do for which is done while awaiting culture reports, it is the most common factor associated with adverse outcomes in CAP. However, as I said, not everybody with pneumonia should undergo this test because the sensitivity and specificity is not very high. There are good amount of false positive cases, and there may be a potential for inappropriate escalation of antibiotic to add, and of course these tests are expensive. So the treatment strategy for is beta-lactam and a macrolide, or a beta-lactam or a fluoroquinolone. Of the two, the beta-lactam and macrolides are preferred treatment for a severe CAP empirically. If you are suspecting Legionella or there is outbreak or a history suggestive of some exposure to Legionella, probably a beta-lactam and fluoroquinolone should be the preferable regimen. Patients who are at risk for developing Pseudomonas aeruginosa or Staph aureus, they should have a appropriate anti-pseudomonal and anti-staphylococcal coverage, especially in patients with severe CAP. In patient with non-severe admitted patients, we can obtain culture and while awaiting the reports for before starting the anti-pseudomonal and anti-staph coverage. Again, empirical oseltamivir during the influenza season should be given, and even if the patient comes positive for influenza, standard antibacterial treatment should be continued. It should not be discouraged because there's very high chances of co-infection post-influenza or any other virus. Use of corticosteroid in patients with CAP only in refractory septic shocks, otherwise especially to be avoided in the viral pneumonia, especially influenza and the RSVs. Duration of treatment should be most of the, if we identify if we start the antibiotic properly, 5 to 7 days is the most common time we can de-escalate the treatment or stop antibiotic, but not to stop the antibiotic till the patient achieves clinical stability. Procalcitonin can help us in identifying the time of stopping the antibiotics, but it should always be taken in conjunction with the hemodynamic stability of the patient. So, coming to non-resolving pneumonia, it's a very big topic on its own. I'll just touch upon few of the things. So non-resolving pneumonia, actually classically it is said that when there's a radiographic opacities fail to resolve within 4 weeks. we start looking for other causes, or probably we term it as a non-resolving pneumonia, but the official definition is NRP is a clinical syndrome in which focal infiltrates begin with some clinical association of acute pulmonary infection, and despite a minimum of 10 days of antibiotic therapy, patients either don't improve or worsen, or radiographic opacity fail to resolve within 12 weeks. So there are two types of, we can divide it into two: non-responding pneumonias, like the patient is put on treatment, he's not responding or worsening or progressing, or the patient is not worsening, but there is some, the radiological clearance is not there, and that is the time when we should think of non-infective causes for it. So causes, it can be the host factors, a comorbid disease, elderly patients, they have poor immunity, they don't respond to the treatment as adequately as a young individual. Smoking, the immunodeficiencies, all this affects the time of recovery of the patient. Malnutrition. Certain pneumonia-associated complications like a metastatic infection, infective endocarditis, or empyema, abscesses. These may be the other reason why the patient is not responding to the treatment. Or it can be an infection with a unusual organism. In India, TB is one of the most common unusual organism, atypical mycobacteria in certain populations. MDR organisms or inappropriate antibiotics, nocardiosis, actinomyces, PCP, fungal infections, again very easily missed, and the patient may not actually be so sick so that we can suspect that the patient is not responding. And certain zoonosis in appropriate clinical setting may give a similar picture as a community acquired pneumonia, but may not respond to the treatment. Non-infectious causes, certain malignancies, especially bronchoalveolar cell carcinoma, very frequently presents with a patch of pneumonia which does not respond to the treatment or partially responds to the treatment. And in a correct setting, early bronchoscopy and a transbronchial lung biopsy helps in diagnosis. Other malignancies, lymphomas, again very commonly presents with a patch of pneumonia on the lungs. And apart from that, there are certain inflammatory disorders which present like a pneumonia with a patch, but may not be a pneumonia and does not show adequate response. Connective tissue disorders, the pneumonitis, SLE pneumonitis, diffuse alveolar hemorrhage, BOOP, sarcoids, all the vasculitis, they all can present with a non-infective pneumonitis picture, and a correct treatment at a correct time can be life-saving. Certain drugs are associated with lung infiltrates and may mimic pneumonia. It may be a non-pulmonary also, probably a cardiac embolism or a heart failure. They can also present like pneumonia and should be. So how do we identify this? First of all, we should see, is it a pneumonia or not? Is the antibiotic correct or not? Whether is there a host factor, like a patient, or a malnourished patient, or an elderly or alcoholic who is not responding, or the or the response is poor. Microbiological data, the cultures, the antibiotics, a drug-resistant pathogen. Repeat imaging, CT scan may sometimes help us in clinching the diagnosis or probably planning the next step. There should not be a hesitation in doing a bronchoscopy or a transbronchial lung biopsy if the patient is not responding and we are not, and if he is on an appropriate antibiotic. If not, in a peripheral patches, even a CT-guided FNSE or can give us a diagnosis. Many times fungal infections and all, it's even with a BAL, we may not get the diagnosis, and a biopsy is needed. To that, there are certain non-invasive tests like ANCA and ANAIF and other tests, and sometimes a background history also helps us in clinching the diagnosis. So to conclude, the mortality from severe CAP remains unacceptably high even with the availability of so many newer antibiotics and vaccination. The most important factor in improving the outcomes is identifying the patients who are going to deteriorate, or identification of severe pneumonia early in the course of disease. Initiation of timely and appropriate antibiotics is life-saving. Understanding the microbiology of severe CAP is the key to starting appropriate antibiotics, identifying the patients who may be infected with non-core pathogens. Rapid PCR-based diagnostic test, when used appropriately, can help us in getting a better antibiotic choice. Non-resolving pneumonia, it's a vast topic, and a syndromic approach may help us in finding out the cause and treating it effectively. Thank you.